Welcome. Thank you for joining our webinar all about DIBH treatments with surface-guided radiotherapy. I'm Josh Naylor. I'm a physicist at University Hospitals Dorset, and I had the pleasure of chairing the SGRT European meeting back in December, held in London and virtually. Now, these webinars are an opportunity to share more widely some of the great talks that were not live streamed during that European event. So this webinar today is the first in a series of 3. Today's webinar is CE credit approved. Details of how to obtain your credits are displayed within the slides. And for all other attendees, you'll get a certificate of attendance and that will be sent out to the email address that you registered with for this event. So on to today's event on deep inspiration breath hold. We have 3 speakers today. The first is talking about surface-guided radiotherapy compared to Varian RPM for deep inspiration breath hold breast treatments. And that's going to be presented by Darina Hickey, who's a medical physicist at the Beacon Hospital in Ireland. We'll then have a talk on end-to-end DIBH at QE Birmingham, and that's right through from CT to Markerless treatments. And it's on their experiences and clinical results. That will be from Julie Kilkenny, who's technical lead practitioner, and Ben Allen, who's a consultant radiographer. Our final talk today is reproducibility of DIBH treatments on Halcyon from Varian, performed using AlignRT InBore. That's presented by Dr. Lorchel and Daniel Nguyen, and they're from the Centre de Radiothérapie de Mâcon in France. And you can tell that I'm not from France by my appalling accent there. At the end, there will be questions, and all of the presenters are available today to answer questions that you may have. If you have some, you can type them into the chat box facility, and then they will get answered by the presenters. So it's my pleasure to introduce our first speaker today, Darina Hickey, and then the following 2 presentations will follow on directly after her.
I'm just going to speak to you all today about an audit that we did when we moved from Varian RPM for DIBH breast treatments to SGRT. We had used Varian RPM for 10 years, so it was a bit of a transition. So we were keen to do an audit just to compare that to ensure that SGRT was just as good, if not better, than Varian RPM. And I'll just go through our results. So just to give you a brief overview of our experience in the Beacon, we have a Varian Edge and a Varian Trilogy, both with SGRT, AlignRT on both. And we got AlignRT in 2014, and we began using it for our intracranial SRS patients for both setup and monitoring during treatment. And in 2017, we kind of started to expand its use into extremities, thorax, abdo, pelvis for intrafraction monitoring only. And then throughout 2018 and 2019, we moved towards using it for setup for all of our patients. And so we went tattooless, and we were using for intrafraction monitoring, and that included then the breast DIBH, which we'll talk about today. And in 2019 as well, we kind of expanded it for intrafraction monitoring for our saber, abdo, and thorax. And in August 2021 there recently, we got the AlignRT Advanced system. So as I said, we had 10 years experience in 2018 or more with using the RPM system for DIBH, which is a marker block that's placed on the CV, and it acts as a surrogate for the patient's breathing. And a visual aid can be used to assist patient breath hold if required, so similar to the real-time coaching used by AlignRT. And we've always done daily imaging and intended to continue doing so with SGRT. And as I said, in 2018, we had 10 years experience with RPM. So what we wanted to compare was that 10 years experience with the first 10 patients of AlignRT. So we took 10 patients from 2018 that we treated with RPM and compared them to the first 10 patients that we were treating tattooless with SGRT. And we were comparing the magnitude of shifts, the total treatment time, and also the number of resetups for both 2-field and 3-field breasts. And then we repeated that analysis 1 year later just to see how we were getting on. So these 3 graphs show the results from the magnitude of shifts that we were getting. So the vert, lat, and long, and the black dashed line shows the if a 0 shift was applied. And as you can see, the blue line shows the RPM, and the SGRT line shows the shifts for our first year using SGRTs with our first 10 patients. And then the green line shows SGRT plus 1 year when our experience kind of settled in. And you can see that there's a very clear shift towards 0 and a peak that's higher at 0 shifts. So we had an increased frequency of imaging shifts between smaller imaging shifts, which is great. And this was less pronounced, but maintained that for SGRT plus 1 year. So I think what we can really say is that SGRT actually does give a more reliable setup, and we have continued to image, but it would definitely beg the question that because your shifts are so much smaller, maybe you don't need to. Then for our average treatment times, with the RPM, we were about 15 minutes per breast patient, and that reduced to about 14 minutes in our first 10 patients. And I think that's why we were keen to have a look at what was happening when we'd been using the system for a year, when everyone was much more comfortable using the system. And you can see that there's a clear decrease there. We saved 5 minutes per patient. We're down 15 minutes to 10 minutes per patient. And then when we looked at additional setups following imaging, so resetups, this was unchanged largely for our 2-field breasts, but you can see a significant decrease. So what I did was I looked at 10 patients using RPM for the 3-field breasts, 10 patients with SGRT. When we were using SGRT, we in the old system before we got AlignRT Advanced, we were routinely using an ROI at the clavicle and the arm region. So that obviously has led to a much better setup. And just to add as well that intrafracture monitoring during treatment has not revealed that the patients are moving particularly much. So just some advantages of AlignRT for breast treatments. Obviously, we've said the arm ROI for our 3-field setups has made a huge difference. And also the treatment capture SSD check, which is arguably more accurate and saves the therapist having to go to the room multiple times. And then, like I said, in August, we got the postural video. So you can see that it's a camera that helps the therapist to set up the patient much easier. And this is just an example. This is one of our patients on her day 1. Her arm position is quite different, and we had no postural video to aid the setup. And this patient was imaged and then needed to be reset up because of her arm position. But when she came on day 3, the AlignRT Advanced upgrade had happened overnight. So we had the system, the postural video, and you can see that her arm position improved greatly. So that's really nice. And then I repeated the analysis of the 3-field setup resetups once we had the postural video. So we've only treated 8 patients, so I'm comparing 8 different patients, 8 RPM with 8 SGRT, and then 8 with the postural video, SGRT plus postural video, and you can see that we've had a large decrease in the number of resetups for our 3-field breasts. So just to conclude, the general feedback from the department and from this data as well is that we have improved accuracy with reduction in magnitude of shifts and a much more reliable setup since moving from RPM to SGRT. And also it's a faster setup, and it's more patient-friendly because we have tattooless treatments, and we've improved safety standards because we have real-time intrafracture monitoring, and we have had a few patients move and had to reset up. And it's been mostly completely a positive staff experience. It's user-friendly and very easy to implement. And just like to thank my colleagues in the Beacon physics team and the radiation therapists and P.T. Kirkland and Ashley Mohan specifically. And that's just a little picture of my holidays in Donegal this year. It's not so bad being stuck in Ireland. Thank you.
Hi everybody, I'm Julie Kilkenny, I'm pre-treatment lead at QE Birmingham. We're quite lucky that we've got SIM-RT on both of our scanners, so we're just going to give a quick overview on how to use that in order to scan some breast patients in DIBH. So there's two pieces of kit that you need. The one on the left is the RTC, which is what you obviously see on set as well. It's your real-time coach. And the picture on the right is a screenshot of a standalone PC that we have in the scanner room. So we have that kind of at the side of the scanner so that the staff can use that PC while they're coaching the patient as well. So from a staff point of view, the patient side PC that we use, the advantages for it is that you're going to use that to coach the patient while you're in the room with them. So it's got an amplitude axis on the left-hand side of the graph, which is what you can use to be able to coach the patient either into a much bigger breath hold if what they've done isn't big enough, or into a smaller breath hold if what you needs to be changed. So this is the graph here, and as you can see along the left-hand side, there's an axis that's in millimetres, and then that corresponds to the chest rise that you can see on the patient. So this particular screenshot shows a patient with a chest rise of around 13 millimetres. So you can see the graph at the bottom. The exhale is taking the patient down to about 0, but when they go into breath hold, it's going all the way up to about 13 mils. So as the staff coaching that patient, you know that that's a good enough breath hold. It's not below 4, which is our minimum, and it's certainly not exceeding 2 centimetres, which we wouldn't really accept anything over that. In addition, you can look at the reproducibility of it. So that was just a snapshot of one breath hold, but you can do that over a couple of times. Make sure that when they relax, they're back down at 0, because that's where they were originally. And when they go into breath hold, that they're going back up to 13, because that's where we coach them to, and we can see that they can manage that. So that would be what you're looking for. If you do that multiple times over, you're looking on the graph on the left that they're going down to 0, and the breath hold on the right, you're looking that they're going up to 13, which is where you saw them go to. So the final thing for the staff here is that you can also assess the suitability. So we know that they're reproducible, we know that the amplitude is big enough, but is it still a suitable breath hold? So what we're looking for there is the amplitude of the right magnitude, and are they leaking? So when we did this by eye, you could never tell if the patient was leaking. You wouldn't be able to pick up that kind of information. But using patient side, if the patient is leaking, you're going to get an image like that. So appreciate the one at the top is a very poor image, but the one on the right, I think you can see the downward trend there, which is where the patient is leaking. Yeah. So they've gone into breath hold, and you think that they're holding it, but actually what they're doing is slowly relaxing down, and they're actually kind of leaking air out as they're holding their breath, which by eye you'd never see that. But to put it into context, that's probably about 1 millimetre, maximum 2 of a leakage there, just to put that into context. But it's something that without using SGRT, you wouldn't see that on your patient. I don't know if you saw the grey box on the top left image there. You use on patient side something called a threshold, so that you can set where you want the patient to reach once you're happy that what they're doing is suitable. And once you've set that threshold, it enables the RTC then for the patient to get involved so that they can see that they're going to achieve their breath hold. And also once the patient's breath hold reaches that threshold and goes in that grey box, a timer will also start running. So I don't know if when you coach your patients at CT, if you ever stand there with a stopwatch or just manually count to make sure that the breath hold that they're doing is good enough, it will time it for you, which is hopefully what that slide is showing there. So as the breath hold goes up into the grey box, there's a timer at the top that says that the breath hold remained in that grey box for 21.5 seconds. So this is the RTC, which I'm really hoping somebody over there is going to be really clever and be able to press play and make it work. So this is what the patient sees on CT. So we've set a threshold. The grey box is the threshold that we just saw on patient side. And the yellow bar at the bottom when the patient is breathing will mirror their chest rise and fall, just like that. So you can see there that the patient's gone into breath hold, taken that yellow bar up into the threshold, it's turned green. So the phrase that we use for our patients is turn the yellow bar green, is how we coach them. And they can see that they've taken that yellow bar up into the threshold where we wanted it to be, at an amplitude that we set because we knew that was appropriate. And now the patient can see that they're doing it as well. So the advantages of the RTC is the patient knowing that they're now hitting the right spot, whereas before they've got our reassurance on the bed, but now they can visually see that they're doing it as well. And it gives them a focus. So when they lay there holding their breath, they've got something to look at, they've got something to focus on, they know that what they're doing is correct. And consequently, I think it helps them feel in control. It's a measurable breath hold in terms of, I think we've all been there when you've got the patient on the bed and you ask for a little bit more or a little bit less and you can't quantify what that is and the patient doesn't know what that is. Now they do, because they can see that they've either overshot it or they've just got a little bit more to go. And fundamentally, you've got that feedback between yourself and the patient that now means something. We do use the RTC to scan. It wasn't how we were trained. But you can use it, you just need to put up the ramp up times of the couch. So I don't know if you can see on that graph there, it enters the threshold, it enters the grey box, and then it quickly drops down. That's the couch ramp up just as you're about to scan. The yellow box on there indicates that the scanner is switched on. This is where the biggest difference for us at the QE has been noticed. We always had rescans with our breasts. Most of it was to do with the amplitude. The breath hold that we did at CT was either not good enough, it wasn't big enough, or it was far too big and then the patient couldn't achieve it when they were on treatment. And it's because it was unmeasurable. We were scanning these patients by eye. So we did an audit pre-SIM-RT and found out that we were rescanning around 15% of all of our breast patients. And we felt anecdotally that had reduced when we started using SIM-RT, so we re-audited and realised we'd now got a rescan rate of 2.3%. And it's purely to do with being able to quantify that breath hold. So for us, it's made a huge difference. So I'll pass you over to, this is not Abdul, this is Ben. I'll pass you over to Ben. So he's going to run through treating the patients after we've scanned them.
So I'll pick it up from where Julie's left off. So once Julie's got that scan, it will go through to planning, and planning will create the plans that they need to, and it needs to be exported into Vision RT then. So Vision RT needs two things in order to work properly. It needs the plan, so the isocenter coordinates importing into it, and it needs the structure set as well, so the skin is the structure set that SGRT is going to use. And the importing process is really easy. As soon as there's a plan ready to import, it appears automatically on your sort of home page, and then you just follow the steps through. You click which isocenter you want to import, if there are multiple isocenters, and your protocol, whether it be SRS or breast, they have sort of predefined tolerances, and then which structure sets you want to import at the very end, and then it's really simple. It doesn't add any time to your sort of patient prep work at all. Once we have imported the structure and the isocenter, which is, you can see the isocenter on the three coordinate arrows, we have to set a region of interest, which I think people have spoken about already, and that's just us telling the system which part of the body to concentrate on. So you don't want it too big because it gets less accurate, but you don't want it too small because it won't be able to sort of fix onto anything. So that's a stereotypical region of interest that you'd set for a breast. This is the main treatment screen. So going across from the top left, you've got your isocenter selection, and then you've got where it says SGRT body, we call that the field. So if you're doing DIBH, our first one would be called CT free breathe, and you'd set the patient up in free breathe, and when you wanted to switch over to DIBH, you just click that drop down and select your CT DIBH, and then top right is region of interest, so you can set multiple regions of interest. So you have to have one for monitoring for treatment, which is your isocenter ROI, but if it was a breast and you wanted to double check chin position or arm position, you can set multiple ROIs and flick through them there. Then on the left-hand side, you've got your 6 degrees of deltas. and that's what you use to actually set the patient up. And the bottom right is what Julie's just talked about, is the real-time coach, but that's how it's displayed on the treatment screen, so you can see it as well as the patient seeing it. So when we're setting up a breast, we're markerless now, so we don't have a tattoo, but the pre-treatment team will still tell us where they've put the laser through the side of the breastboard. So the radiographers will get the patient on the bed, they'll raise the bed up till the vertical delta is good, they'll move it lateral until the lateral delta is good, and then they'll set 37, for instance, on the breastboard scale. Now, if the longitudinal delta isn't perfect there, that's purely the patient's position on the board, so we just get the patient to shuffle up or down the board until they're within about 1 centimetre, and then we'll fine-tune it with the actual couch longitudinal at that point. We've also got postural positioning at QE, which has been mentioned as well. Instead of just getting the render, the sort of skin render with a region of interest on, you now get a live feed image from each camera, so that's really helpful for positioning chins, arms as well, because it's just a really quick visual aid to see if you might be wildly out of position, you can see straight away. So that is what the deltas would look like if we were setting a breast up and we needed them to shuffle 1 centimetre down the bed. That's what the delta looks like, and then once they are down the bed, it will look how it looks on the right hand side of the screen. And that's when you're in a position to switch the machine on. And if anything went red at that point, VisionRT would interrupt the LINAC delivery. This shows you what postural positioning is. So it's all automated, so you don't have to draw any of these contours on. It just recognises contours on the patient and automatically outlines where they should be. So you could see if that phantom's head was over to the left, you could see where those pink contours were to reposition them. And it's just a really nice visual aid that speeds things up for us. I have got a video. I don't... Oh, is that going to play? Will that play? Yeah, so if we play that, that shows how postural imaging works. So how our arm's moved, and you can see where it should be. And you can see the deltas flicking in and out of tolerance as well. And before we had the postural, you might spend a little bit of time trying to figure out how you need to correct that delta. Whereas now we've got postural video, it's an immediate answer. You can just look at it and go, oh, okay, it's definitely the shoulder.
Sorry, where's the ROI in this case?
That you'd have to flick back on the bottom of the treatment screen. You flick between postural and your standard screen, so you just flick between the two to get your ROI back on, because the ROI is kind of superimposed onto the skin render version. Julie's already talked about the real-time coach. We've always had it on set. I think it's really beneficial that Julie's now got it in pre-treatment, because part of the problem was if Julie didn't know the patient was leaking upstairs, we would set the patient up, you'd start your treatment, but that leaking would take you out of tolerance. So it's really helped things. But yeah, we have it downstairs as well. The patient can see it, and it's just really nice to be able to tell them, to show them what they need to do. So when I'm coaching a patient on day one, I'll just get them on the bed, put the real-time coach in front of them, and just let them breathe away for a minute or two so they can see how they're in control of it. And that's a nicer way for them to sort of understand how it works. So the advantages of AlignRT overall, especially for deep inspiration breath hold, is that it's non-invasive. It's all completely remote from the patient. That's what drew us to it originally, sort of 5 or 6 years ago. We don't have to put pen marks even on the patients. We don't tattoo them anymore. It gives us a quantifiable breath hold at CT. It also gives us, when the deltas are moving around, there's a figure next to it. So when you switch over from your free breathe field to your deep inspiration breath hold field, as well as a visual red delta telling you you're not in the right position, there's a figure next to it telling you exactly how big that breath hold will be. So it gives you all that data, and it's really quick and really accurate. And this slide just shows in the top left figure, 28.1%, that's how many correctional shifts we were putting on breast patients. before we used SGRT on them, and with SGRT we've reduced the sort of correctional shifts down to 5.4%. So that's nice for the patient, it's nice for the radiographers too. And front row is SGRT setup times, so it's heavily weighted to the left, which is quick, and the back row is the tattoo setups, which are obviously taking a little bit longer to set patients up with our traditional techniques. That equates to total time spent in the bunker. I'm not saying that you have to fill that with more patients, but if you've got capacity issues, you can, or you can actually just spend more time with the patient rather than being like a conveyor belt when you're busy. And it's about, on average, 1 minute 7 seconds saving per patient, which doesn't sound a lot, but when you've got almost 3 linacs back-to-back with breast patients, it really adds up. So in conclusion, AlignRT and SimRT is really simple and friendly solution for DIBH and Markerless. It's accurate, it's fast, and yeah, thank you for your time.
Good morning, I am Dr. Fabrice Lorchel, and I would like to thank the SGRT community for inviting me to present the results of our study entitled Reproducibility of Deep Inspiration Breath Hold Treatments on Halcyon, performed using AlignRT InBore. I would especially like to thank Mr. Jad Farah, engineer at Vision RT, and Daniel Nguyen, physicist in our Radiotherapy Center, who allowed the development of this onboard surface repositioning system with the Halcyon, and Mr. Nguyen presents this study with me. The development of this product stems from a collaboration between our group of radiation oncologists from the region of Lyon and Mâcon in France, and the company Vision RT, whose objective was to develop an SGRT solution dedicated to the Halcyon of the company Varian.
So indeed, when we acquired Halcyon in our radiotherapy centers, the advantages were a wide treatment field as well as the realization of a systematic SGRT at each fraction, thanks to the CBCT acquired in about 20 seconds. Moreover, it gets a high dose rate of 800 monitor units per minute. Its dual layer multi-leaf collimator allows IMRT, VMET, and stereotactic radiotherapy treatments. However, the limitations include the positioning outside the ring without internal lasers, and the inability to follow the intra-fraction movement of the patients. So what to say about the fabulous project to develop the surface solution under the Halcyon? It started in May 2019 with the development of the new mini cameras, and we received the first fully functional prototype by November 2019. And in March 2020, we began its use in clinical practice with patients treated for breast cancer. The AlignRT platform, as you can see here, combines the standard ceiling mounted cameras for patient setup outside the Halcyon bore and the new ring with mini cameras for intra-fraction motion tracking.
After the development and validation of the system, we started a study called CYBER. The goal was to assess the reproducibility of the DIBH treatments for patients with left breast cancer, a treatment which may limit the cardiac radiation toxicity. For this study, we quantified the repositioning and treatment times of the patients, analyzed the internal movements of several anatomical structures, compared the shift on CBCT by therapist and the radiation oncologist, and finally studied the reproducibility and stability of the DIBH. From November 2020 to March 2021, we included 22 patients who were able to maintain apnea for a minimum of 20 seconds, which corresponding to the time of acquisition of a CBCT on the Halcyon. And all patients signed informed consent. During the simulation scan, the patients were positioned in a supine position over a 5-degree inclined breastboard device. Reference surfaces were acquired in free breathing and deep inspiration breath hold using these SGRT cameras. Patients could follow their respiratory amplitude using the RTC visual system. And finally, 2 dosimetric scans were performed, one in free breathing and one in DIBH. In the treatment room, patients were positioned at the ISO center using standard AlignRT cameras outside the ring. Then intrafraction movement monitoring was followed in the bore with AlignRT InBore cameras. Session duration and CBCT shift were retrospectively collected using ARIA system from Varian. Secondly, setup time, CBCT analysis time, number and duration of breath hold required for treatment delivery were manually recorded by the radiation therapist at the treatment console, as well as the number and duration of each treatment breath hold. A retrospective offline review of CBCT images was undertaken by the senior physician to individually verify the compliance of breast, heart, spine, sternum, and lung dome positions. Patient characteristics were mean age of 63 years, a mean height of 1.60 meters, mean weight of 63 kilograms, and body mass index of 24.6. 27% of patients had conservative surgery and 23% had mastectomy. 27% had breast or chest wall irradiation alone with IMRT. And 73% of patients had regional lymph node irradiation in VMAT. The prescription dose were 50 gray for breast or chest wall and 47.5 gray for subclavicular, axillary, and internal mammary chain. Treatment planning were performed using Eclipse or RayStation. The setup and treatment time were 4.5 minutes for setup, 1.1 minute for CBCT analysis, 14.2 minutes for overall treatment time. The number of breath hold per fraction was 4 and the duration was 27 seconds. These results allow to conclude that the processing times are fast, less than 15 minutes, including setup, imaging, validation, and beam delivery, and that this treatment can be offered to a wide majority of these patients. And then you can see a box plot representation of session duration and setup time for all 22 patients. The analysis of linear mixed model coefficient shows a learning curve for mean setup and treatment time, by fraction and by date, with evidence of an improvement in inspiration breath hold in patients during treatment and an improvement in the control of the system by therapists. We can see on this slide the average CBCT shift performed online by the therapist in all 3 directions and magnitude. All of these shifts are less than 5 millimeters, except for the magnitude, showing the reproducibility and precision of the DIBH. Regarding the offline analysis of the 115 CBCTs, this shows, for the different structures studied, mean shift in absolute value of 2.3 millimeters for the breast, 2.9 millimeters for the heart, 5 millimeters for the lung domes only in the vertical direction, 3.3 millimeters for the spine, 3.2 millimeters for the sternum. And the three-dimensional magnitude shifts remain within 3.5 millimeters for all organs, showing reproducible DIBH and compliance with local clinical and dosimetry margin that are 5 millimeters in our center.
About internal organs positioning, these box plots represent the vertical, longitudinal, and lateral shifts per organ following offline review of the CBCTs. Also highlight the compromise one takes when looking at all structures in the CBCT compared to individual registration of each organ. When apply such CBCT shift, all organs except the lung dome are likely to be within 2 millimeters of the expected position. In opposition, should the decision be made solely relying on the position of the lung domes, may result in inaccurate positioning of the heart. So these patients are treated with the thoracic DIBH technique, and currently we are treating patients with the abdominal DIBH technique. It looks better at the pulmonary filling level. We have to analyze the patient data with this method in order to compare them with those of the first method. Here, DIBH reproducibility and stability. The graphs show the mean vertical amplitude of successive breath holds. When we compare the absolute vertical position across 4 successive treatment breath holds, Wilcoxon inferiority tests show no significant difference for all patients and sessions. Here, the absolute slopes of the vertical amplitude deviation during DIBH were analyzed to evaluate the stability of the DIBH during each treatment fractions. We can see for all patients except 2, the mean absolute linear slope of the vertical amplitude deviation during DIBH was lower than 0.1 millimeters per second, confirming the stability of all the DIBH during all treatment fractions. Here, the mean absolute vertical amplitude deviation for a total more than 1,500 DIBH are presented in the figures below. The linear effect of the fraction on the mean absolute vertical amplitude deviation given by the linear mixed model was found to be close to 0 millimeters. Such an error difference between the fraction could hence be considered as negligible, proving reproducible DIBH.
In conclusion, in this study, we have shown that AlignRT InBore allows for fast and accurate setup and treatment for patients with less breast cancer treated in DIBH, and there is a strong correlation between positioning with AlignRT InBore and CBCT.
About the work to be done, it will be necessary to analyze data from patients treated with the new procedure, then analyze the data for the coaching sessions and correlate with those of the treatment, and finally make a comparative dosimetric study with free breathing and DIBH. Thank you for your attention.
Thank you. Bye.
Bye-bye.
Thank you so much for joining us today. Just remind you to complete the quiz for credits, and the session will remain open for a little while so you can complete that. I really hope to see you next Tuesday at the next SGRT webinar, and that will be focusing on stereotactic radiosurgery.